All right. Sorry about recording late, guys. I just remembered people were asking for it. Cool. But yes, know the difference in the mast cell stainings, know which ones are granulation dependent, not degranulation dependent, and definitely know c-KIT or CD117. All right, let's start here. So what are you guys seeing over here? So you have a shaved biopsy and you have an infiltrate. What kind of cells do you think are making up this infiltrate?
Histiocytes.
Yeah, okay, good. Histiocytes. Now, let's ask the question. Besides the histiocytes, what are we seeing in terms of these fibers? Or not
fibers, maybe
fibers could be
elastic fibers.
It could be elastic fibers. Could someone with solar elastosis also have mucin?
Yeah, but I thought mucin is not so like clumpy.
It's not. Well, sometimes it can look. So here's the thing. Typically not. Sometimes it could look a little more clumpy than we'd like. So look, so the point here is that you can have both. You can have these fibers, but then you could also have mucin. There's nothing about having solar elastosis that prevents you from having mucin. So how do we tell if it's, so three options. Either there's neither, there's both, or there's, well, four options, or there's the solar elastosis, or there's the mucin only. So how do we tell?
Stain it.
Okay, that's one thing you could do. That's one thing you can do if you want to cheat. You can cheat your way through it. Okay, but you're not going to do that. You're a baller. Okay, you are a dermpath expert. You're going to look at that on H&E. You're going to impress everyone. So how do we do this on H&E? How do we tell the difference between mucin and solar elastosis?
I thought it was like the depth.
Okay, good. The depth.
Yeah.
Do we see the bluish tinge and everything?
No.
Like this, and this, and this, and this?
Yes.
Yes. In fact, you almost see something that looks like fibers here. Look at this. So you'll notice there's a difference because it looks much more pronounced here. There's a reason for that. The reason for that is because you have both. You have solar elastosis. You also have mucin. And I'm just going to prove that to you, but look at the normal skin. Let's look at the normal. Let's ignore the lesion. Look at what's normal here. What's this?
Solar elastosis.
Yeah, solar elastosis. Now look, how deep does it go? That's it. There's your cutoff. That's how far the sun shined. Now let's go back here. This is way too deep to just be solar elastosis. But you can see it. You can see it interstitial between the collagen bundles. They're spreading apart because remember that hydrostatic pressure, and here it's staining. So this patient has both solar elastosis and mucin. The solar elastosis here is probably just incidental. It's just part of the normal skin. The person had sun exposure, big deal. But the point is you have to be able to look at this and say, okay, well, I understand that this is not just something I'm going to ignore just because it was more pronounced over here. That's just because I'm seeing both the mucin and the solar elastosis. So, histiocytes, palisaded or interstitial?
Interstitial, so
interstitial.
Probably interstitial GA.
Interstitial GA, okay. So we're about to, we patted ourselves on the shoulder. We did a very good job. We recognize there's mucin. We recognize that there's these histiocytes and it's interstitial. So we're going to say interstitial GA. But we have to look at all the cuts. And here we have a problem. Now, can we just sign this out as interstitial GA and call it a day? What's going on here?
There's like a lot of like crusting. Like it looks impetiginized.
So okay, so it probably is impetiginized outside here to some degree, but what is it? Is it more than that? Is there some loss of the?
Yeah, I guess we're down to dermis, so it's like a
We
proper
are.
ulcer.
Yes, we're down to dermis here as well. Okay. And what is all of this made of? So it's like, so there's some crust here, but look at these fibers. What are these fibers? It's almost like a
Oh, it's collagen.
collagen and these cells
So
actually
it's perforating.
perforating. What? Okay, so perforating, but it's not like, it doesn't really quite look like elastase perforating sponginosis. It doesn't really look like a collagen. Like, what's different about this from like reactive perforating collagenoses or curlies is that they don't typically have these histiocytes going through it at the same time. So what kind of perforating thing is this?
Perforating GA.
Perforating GA.
But wait, I have a question, and it's
Yeah.
probably like a dumb question. And
You
but
don't, everyone
when you
says this.
say
It's not a dumb question. Okay.
mucin and increased histiocytes in the top 1/3, isn't that also kind of like a scleromyxedema thing?
Increased mucin and increased histiocyte. Is it increased histiocytes? Let's take a
Is
look.
it? But you know what I mean? Like, how do I? how do
I know. Oh, I
get
know
myself
exactly.
in GA direction and not in the mucin? I guess is there just not enough mucin also?
I know exactly what you mean. But let's answer the question then. You tell me. So what do you think this is?
See, like if anything, I feel like this looks less cellular, but it looks different, and I'm just like, when you can't figure out why it looks different, more mucin.
There's a reason it looks less cellular to you. What
Because there's
kind
more
of cells?
mucin.
Okay, so there's mucin, but what kind of cells are these?
Fibroblasts.
Fibroblasts, right? That answers your question. So it's not that there's an increase in histiocytes and mucin. There's an increase in fibroblasts for scleromyxedema. So and it's so top third, it's more cellular. We all agree that this is less cellular than this, right?
Mm-hmm.
Okay. And so the difference is just the cell type. So there is an increase in cellularity. There is an increase in the mucinous component of the top third for sure. But it's not the histiocytes here. So increase in histiocytes with mucin, your top of your differential should be GA until proven otherwise. If it's increase in mucin and fibroblasts and it's just the top third, that's going to be scleromyxedema until proven otherwise. By the way, now that we're talking about scleromyxedema, what's the most common association that patients have with scleromyxedema?
I know it's a gammopathy, and I think it's IgM.
It's a gammopathy. It's a, well, if it's a gammopathy, it's an IgG, right? Because it can't be an IgM. Because you already said it was a gammopathy. What type of gammopathy?
IgG lambda.
Lambda, yes, lambda.
Lambda.
Compare that.
My brain.
Compare that to NXG. What's the most common gammopathy in NXG?
That one's IgG kappa.
Kappa, yes.
That's what I couldn't separate out.
Yes, about 8 of the people with NXG, about most of them are going to have IgG kappa. That's right. And people with scleromyxedema, most of them are going to be IgG lambda. A minority of patients with NXG will have IgG lambda. A small minority of patients with scleromyxedema will have IgG kappa. So it's the reverse. So NXG is, in that sense, the reverse of scleromyxedema with the lambdas and the kappas. There's your detour.
Avi, sorry, just to harp on this one. I guess when I saw the elastic fibers, I was thinking more like the actinic granuloma.
You're saying in this one?
No, the last one with the.
That was also my first thought.
Yeah.
Oh, I see. Yes.
But I guess that would be more palisaded.
Well, what's the Well, here's the thing. What is lacking in actinic granuloma? Mucin. There is no increased mucin in actinic granuloma.
Okay.
In fact, that's one of the hallmark differences. Actinic granulomas don't have the increased mucin, unlike GA. So that's why this is so important. And I agree, this could be an easy throw off. When you look at this, you see the histiocytes with these, and it really is solar elastotic fibers. You can totally talk yourself into this being an actinic granuloma. So one thing you need to do is you need to say, okay, I'm going to track this down. I need to rule out the presence of mucin here, because this could just be GA with a patient with solar elastosis. So this is perforating GA in a patient with a background of solar elastosis. And you guys got it. Okay. Some sort of infiltrate here. We'll see what's in the box. Now, what does this look like? It looks like a type of cell.
Are they plasma cells?
Yeah, it looks like plasma cells. I agree. In this case, it looks like plasma cells. There's something a little bit off about it for plasma cells, though. There's something that's not quite right. And this is important because there are certain types of ways that this entity can present that's not really the textbook, but there's a key feature that is underlying and subsumes all of them. So look at the cytoplasm. Is it perfectly smooth, the cytoplasm, or is there some stippling or granulation to the cytoplasm? Perhaps
Yes,
we can
it's a little stipply.
stippling and granulation. Perhaps we can go to another field and we can hone that in more. But that's a key feature of this. And you'll notice that the nuclei are not all this like toward the side the way you'd expect in a plasma cell. Like here you actually look, it's almost like two nuclei in one. Here it's dead in the center. They're not all to the side. And then we can give it away if we go to some other fields. But yes, notice the granularity of it. And now it becomes more obvious when you look at other sections. There's a reason they're granular. Do you think these are plasma cells?
No, they're mast cells.
They're mast cells. So notice how conspicuously like plasma cells those mast cells look like over here. You could totally talk yourself into this being a plasma cell. The issue here is that plasma cells don't have granules. And these cells do have granules. The classic picture that you'll see with this mastocytoma is something like this, these monotonous fried egg appearing cells. By the way, what are the three things that should come to your mind immediately when you see a monotonous cells like these?
Mast cells, poroid cells, and glomus.
Yes, mast cells, poroid cells, and glomus cells. They can all have that very conspicuously monotonous feature. Okay, very good. And then we covered, remember, c-KIT, CD117, that stains your mast cells. And it doesn't matter if they're granulated or degranulated. Now, what does this look like? If we were to bet what type of cell these were.
Langerhans cells.
Yeah, so it looks like a type of histiocyte, right? It looks like you can see the nucleolus, what looks like a nucleus. What's wrong with this, though? What's off? Because otherwise, I totally agree. You could totally talk yourself into these being histiocytes.
I feel like they look really reniform. So many of the nuclei look like kidney beans to me. Are they not Langerhans cells?
They're not Langerhans cells, and I agree that a lot of them look reniform. I agree. I'm telling you that this is not the textbook, but there is a way you can know. What's wrong? What's wrong with Langerhans cell histiocytosis here, just right off the bat? Look at the cytoplasm. Stippled? Granular?
Yes.
Yes. Very granular, very stippled. It's full of, these cells are all chock full of granules.
So it's another mast cell?
These are mast, yes, good. These are mast cells, and there's a reason all these eosinophils are following them. So yes, mast cells can look like plasma cells. Mast cells can look like histiocytes. Mast cells can even look like Langerhans cell histiocytosis in some cases, believe it or not.
I feel like the granularity is not helping me because there are so many entities that have like foamy histiocytes and like those. I guess you just need tons of experience to actually be able to tell the difference between foamy and granular.
Yeah. So a couple of things. So you have to be able to differentiate foaminess versus granularity. You should, but you can pick up a couple. Okay. So a couple of things. First off, the degree of eosinophils here should be raising an eyebrow for you. But then otherwise, if this is foamy, so yes, you can talk yourself into this being foamy histiocytes in some sense. Let's see if there's any other areas. Like here they become a lot more monotonous. But like, if you look over here, if they're foamy, you typically see like these types of, you see some bubbles over here, but even in the areas where you don't, look at the areas that are just right close to the nuclei. Even in the cytoplasm, like, okay, so you can talk yourself into being foamy outside of, like, toward the periphery of the cytoplasm. Look at the areas that are just right next to the nuclei. If these are foam cells, they're the tiniest foam cells ever in terms of those little foamy bubbles. And they're so persistent throughout each one of these cells. But yes, I agree that some of this does come with experience, and you probably won't be tested that difficultly. I will tell you though, and this is to your point about how this comes with experience, I showed this to Dr. Need. And guess how long it took him to say that there was that these were mast cells? If you were to guess. I just showed it to him on the screen.
0 seconds.
Yeah, like 1/2 a second. He looked at this and it was across the room, by the way. I showed this to Dr. Need across the room. I'm like, oh, I'm gonna get him here. I'm gonna convince him that this is Langerhans cell histiocytosis. Because of the reniform nuclei, right? I had the same idea as you. So I showed this to him across the room on the computer screen. In 1/2 a second, he's like, oh no, it's way too granular. These are mast cells. 1/2 a second he did that. So that's, I mean, that's what comes with years of experience. Okay. What are we seeing here? By the way, if you're confused over here, you can always stain it. You can always, like, you don't have to just like, okay, well, I have to sign it out now. You'll do your stains just to confirm, and that's how it's done in practice. Right. So you can tell the difference. You know what stains to do to differentiate from being a mastocytoma versus this from being Langerhans cell histiocytosis. So what are we seeing over here?
Is it just keratin?
Yeah, it's okay. So what layer of the skin?
Stratum corneum.
Stratum corneum. What's going on with this stratum corneum?
It's like papillated, but
Okay.
there's no epidermis or.
Yeah, now that could just be because it's missed. You know, this is a very thick stratum. You can imagine, I mean, look at the size of this. This is this is a very hyperkeratotic stratum corneum. You could easily imagine that someone may have done a biopsy here thinking they got what they needed to get and understand why they didn't. Right? It's like, hey, look at how much I got. Well, okay, but here's the problem. So one thing that Dr. Need always loves to ask me is how old is the patient for various conditions? So if you're ever on the scope, how old you'll hear, how old is the patient? In this case, you'll have an answer for Dr. Need, okay? You're going to say the patient is -2 months. Hasn't even been born yet. This is a biopsy of a fetus. And you got the stratum corneum. Now what do we think? You can give me a broad category. You don't have to give me a diagnosis specifically. What do you think these dilations are over here?
Are they like? I almost don't want to say it because it sounds ridiculous, but could they be hair?
Okay, so that's no, that's not a ridiculous thought. In fact, in this condition, there is keratinaceous material that builds up in the hair. These are not actually hair. These are, although you can see there actually is a little bit of hair shaft over here, but these aren't really what makes up the hair. These are actually dilated tortuous chambers that represent the acrosyringium. The sweat ducts are percolating through here, but it's huge. It's massively dilated. That's another thing you can see in this condition. And you can also see keratin, these keratin plugs that form. And there is keratinaceous material if we were to see hair. But the key thing is there is a lack of desquamation. There is an increase in the stratum corneum to a very pronounced degree. And if we were to see the rest of the skin, it wouldn't be as pronounced as this. So what condition, what type of category of conditions can we see this sort of thing happening in a person so young that they're not even born yet?
Like ichthyosis or like clodian membrane or something like that.
Yeah, some kind of ichthyosis. We're thinking all right, we're in this, okay, it's got to be some kind of genoderm category. This is there's going to be some sort of problem here. Now, of the ichthyoses, I will tell you that there is one ichthyosis that gives you a stratum corneum this large and this massive, right? So just think about like the ichthyosis. What gives you like this brick type of like cracked appearance?
EHK.
So
no.
EHK is going to be, now that we're on EHK, actually we'll get to EHK, but like think of just how thick the skin is. I mean, it's so it's not, so EHK, we will talk about EHK. So EHK, what would you expect to see? And you're not seeing it over here, but EHK, see if I have it. I do have it. I know I have EHK.
Well, that one I would expect to see like the granular layer.
You would want to see the
Or, like,
granular. What would you
yeah,
expect to see in
it
the
would be
granular?
like shot or
Yeah, exactly. You see the vacuolations and the tonofilaments. Right. In this case, what we really see is it's not a problem. Well, it's sort of a problem of the granular layer, but it's mainly a problem of a lack of desquamation. So let's give a little bit of more information. Let's pretend we did have the granular layer. So here's our interface. Here's our granular layer, and here's our interface between the stratum granulosum and the stratum corneum. You can work the patient. So we work the patient up. Okay, some sort of ichthyosis. We do the standard workup. It comes back positive for mutation in ABCA 12, ABCA 12. So now what are we thinking?
Lamellar ichthyosis?
Okay, if it was
Oh.
lamellar well, it could be. No, technically it could be. Now, for lamellar ichthyosis, is ABCA12 the most common protein affected? Is that the most common mutation?
I guess not.
What is
I think it's
the most common one?
TGM. Yeah.
TGM. So TGM is the most common one. However, type 2 lamellar ichthyosis is ABCA12. So you're not completely and there's an interesting point that we'll get to. So type 2 lamellar ichthyosis is ABCA12, but what is also ABCA12? What is ABCA12?
Can you tell none of us are taking peds along with the dermpath core?
Oh, that's right. You got it. Okay. So it's the ATP, it's the cassette protein. It is the ATP binding cassette transporter. Okay. So the ATP binding cassette transporter is in the superficial layer of the stratum spinosum and the stratum granulosum. So so you have these lamellar bodies. Okay. So these circles are all your lamellar bodies. And in your lamellar bodies, you have this transport protein. That's ABCA12. And ABCA12 takes all sorts of things and puts them into the lamellar bodies. And then the lamellar bodies at the junction between the stratum granulosum and the stratum corneum dump those contents. And that helps preserve your lipid membrane so there's a bunch of lipids, there's ceramides, it preserves your water loss. But also in these lamellar bodies, there are proteases and there's inhibitory proteins, and that regulates desquamation as well. So ABCA12, when ABCA12 is mutated, you can still have lamellar bodies. So one thing that you may hear is like, oh, there's a problem with, you can't make lamellar bodies. No, you can make lamellar bodies. The problem is you can't put the right things into the lamellar bodies. So you can't put the right lipids in, you can't put the right proteases in, and then you have a problem here. So mutation, the most common mutation, so harlequin ichthyosis. Harlequin ichthyosis, the main thing you got to think about, ABCA12. ABCA12, it's ATP transmembrane cassette binding protein. It regulates the lamellar bodies by transporting lipids, ceramides, even proteases into these lamellar bodies that will be dumped at the junction of the stratum granulosum and stratum corneum. That problem with desquamation is why you get this phenomenon happening. So the diagnosis here was harlequin ichthyosis. But yes, you guys, you're getting, that was very much the right category. So yeah, so on the dermpath core, by the way, so you don't forget all of your other stuff. Don't forget your genderm. You can have a little bit of a genderm on dermpath. You can have a little bit of peds derm on dermpath core. And they do ask that. So there's always a little bit of tie-ins and overlaps from one core to another. That's true for the med derm core, by the way, as well. Like I remember on the genderm core, there was a path question. There was just a straight up path question where they just give you path and say, what's the diagnosis? There was no thought process in there was no medication management. There was no clinical. It was just a question right out of like a dermpath Q bank. You said, oh, well, here's genderm. Now here's a random dermpath question. You might get that on a derm. So the truth is vice versa. You might get that on dermpath core. You might just get, oh, well, hey, what's the mutation in this genoderm? All right. What are we seeing here?
Something sort of diffuse in the, like maybe closer to like between the papillary and reticular dermis. I think it's like going in between collagen bundles, but I can't quite see what it is.
Okay, good. All right. So you're picking up that there's something here that's not that you're gonna have to look at. I zoomed in a little bit more. I'm gonna zoom in a little bit more until someone sees it. All right, do we see it now? What about now?
The elastic fibers are broken,
Yes.
so it's PXE.
PXE. Subtle. It's not that this was a subtle, it's a little bit subtle, this PXE. But yes, you have to be able to differentiate these collagen fibers versus these calcified elastic fibers. So there's two types of questions, like anything else. Two types of questions on the same entity you can get, right? There's a give me, right? Everyone sees this. What's this? Let's just ask, is it subtle?
No, definitely not subtle.
Definitely not. And what is it?
It's elastolysis in the middermis. Is this middermis elastolysis?
Well, these are calcified elastic fibers. This is just PXE
Oh,
again.
this is PXE again.
I'm showing you the give me question versus the subtle question. So this is the give me version. They can give you this, and this is like, here's a free point. Please take it and pass the exam. Right? They give you here, look, this is what PXE looks like. Here are your elastic fibers that are all lovely, all nice and lovely and calcified, and they're screaming at you, hey, I'm PXE. Hello. But they don't have to do that. They don't have to be that nice. You can get something like this, where it's a little something you have to be able to look and distinguish the collagen versus these elastin fibers. What's the mutation in PXE, by the way?
ABCC6.
Yes, ABCC6. ABAC6. Okay. And then how do you want to work this patient up? What do you want to where do you want to refer them to, and why?
They have eye stuff.
They do have eye.
Angioid streaks.
Yeah. Okay. Why? What's the reasoning behind that? Like, what's going on with the eyes?
Because there's also elastic tissue in the eyes.
Yeah. What part of the eye? What part of the eye has the most like concentration of elastic fibers?
Is this one the one that's like Brooks membrane or
Yes.
something?
Good. Brooks membrane. Brooks membrane is right. Is that that membrane? It has of all the parts of the eyes. There's a very high concentration of both collagen and elastin fibers, and that can calcify, and the Brooks membrane can crack, and then you get a vascular proliferation through it, and then you get those lovely streaks. So you want to throw them to opposite. What else can calcify in these patients?
I'm gonna go with vessels because vessels have elastic tissue.
Yes, yeah, vessel. Anything. So anything with the elastic fibers, really. I mean, you can. Very unfortunate, but yes. Okay. Which of our attending loves this diagnosis, by the way?
Dr. Lebwell, but I don't know
Dr.
why, but I associate it with him.
Yeah, Dr. Lebwell, I think he's done some good work on this. But yes, this is Dr. Lebwell. I think it's his favorite diagnosis. But don't quote me on that.
I think he has a sign named after him for this diagnosis, the Lebwell sign.
Oh, really? What's the level? Okay, well, now
I don't know.
you're gonna have to tell me about that.
It's prominent mental crease. I have it in my notes.
Oh, that's right. I did know that. Yep. Okay, that's why it is. Okay. The Lebwell sign. That's okay. That's good. Okay. Fair enough. Okay, what are we seeing here?
Maybe like some homogenization in the papillary dermis
Okay.
versus just nothing. I can't really tell.
It's not okay, good. Don't be afraid to say nothing. That's a very important thing in dermpath. Like, when you guys say, what's the pattern? Just look over to Dr. Need and say nothing. There's nothing going on here. We're missing something though.
Granular layer.
Missing a granular layer. Okay. Fine. Good. But you have a stratum corneum though. So it's not like, so unless this was like something's going on here, it's not like this is a mucosal surface.
So maybe this is in the nothing pattern. It can be an ichthyosis.
Can be an ichthyosis.
IV.
So what kind of ichthyosis? has a loss of a granular layer, but what's weird when we have a loss of a granular? What's the heuristic we have? Typically, when we have a diminution of the granular layer, we expect to find what in the stratum corneum?
Parakeratosis.
Parakeratosis. General heuristic, diminution of granular layer, you're expected parakeratosis. What if there's an increase, and if there's, by contrast, what if there is there's parakeratosis and okay, so that's the heuristic. Now there's some conditions that violate the heuristic, right? So what's a condition that gives you parakeratosis, but like you have a whole bunch of, like, if anything, you have like tons of parakeratosis, but also tons of granular layer, to the point that the granulars are even in the stratum corneum.
The axillary granular
Granular
something.
parakeratosis, exactly. Okay, so that's a one sinner. It violates the heuristic. What's the other sinner that violates it in the other direction, where you have a diminution or an absence of your granular layer, but you have no parakeratosis?
Ichthyosis vulgaris.
Ichthyosis vulgaris, exactly. And what's the mutation there?
Filaggrin.
Filaggrin, good. Okay. So your nothing pattern is important. Be able to go through your nothing pattern. So first thing, recognize that it's a nothing pattern. Recognize, okay, there's really not much going on here. And then be able just to go top to bottom. Like, okay, when you see, look for organisms in the stratum corneum. Fine, don't see anything there. And then immediately your next finding is going to be right here. Like, oh, wait a minute, where'd my granular layer go? So that's an important, the nothing differential is an important differential.
Didn't you just tweet this photo?
No. This is not okay.
It's not as bad. Okay.
It's not okay. That photo, I'm glad you mentioned it, because we're going to talk about that. Okay. Guys, I love you all. Please, 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 though, when we have inflammatory conditions, when we have a condition where, or if you're worried about a tumor going deep, don't pull out the Gillette. We don't want a Gillette sign. Now, this is not a Gillette sign. I'll agree. There's a little bit of dermis in here. All right. But if we're going, and you know what, I'll just pull it up. Okay. I'll pull it up. Where's my profile? Okay. Don't do this. This is the photo I tweeted. This is, by the way, this guy's awesome. He used to be a fellow at Jefferson, and now he is dermpath at Stony Brook. Daniel Luzio. So this is the Gillette sign. This is the last thing you want to see. So I know you want to spare the patient tissue, but if it's rule out deep fungal versus vasculopathy versus calciphylaxis versus other, this is not fun. Okay. Rant over. So it's not, we don't have a full Gillette sign. All right. But we actually do have enough to make a diagnosis here. And you can make it right now.
See the is this porokeratosis?
Porokeratosis. And I made sure to stay low power, because if I just zoomed in, what am I going to do? Remember, poro can look, the center of a poro, when I'm between choroidal lamellas, can look like anything. You can have a lichenoid pattern to porokeratosis. You can start seeing all these vessels, but that's just incidental vessels, because it's probably on the leg somewhere and there's nodular angioplasia. Don't tunnel vision the porokeratoses. All right. Stay low power. You got to be able to pick it out. Right. It's here. There's one. There's one. There's another one. So when I zoom in, what am I going to see? What is a coronoid lamella?
Stack of parakeratosis. So
Yeah. All right, so that's angular, the 45-degree angle or so parakeratosis, and what more importantly though, so everyone knows, oh, it's the stack of parakeratosis, but what's more important about a coronoid lamella?
Yeah, like the diskeratotic keratinocytes underneath it.
Yes. Good. That's why. That's the reason why. The entirety of the reason why you have the coronoid lamella in the first place. More important than knowing the stack of parakeratosis. So that's obvious, that's standing out to you, is be able to see this. Be able to see this. Be able to look at this. And I will tell you this right now, whether you see it in the slide or maybe it's on the cut next door or the cut in front of the screen or behind the screen. Every coronoid lamella has dead reds. Every coronoid lamella, it doesn't matter what type of porokeratosis it is. Any porokeratosis, it could be porokeratosis tichotropica, the coronoid lamellas have dead reds. If you see something that's a coronoid lamella, you should see the dead reds. They're there. And if they're not there, it's either not a coronoid lamella or you've just missed it. Here they are as well. That is the entire, and the reason they all have it is because that's why you have the para. That's why you have this stack. It's because you have these dead reds. So yes, low power, recognize this stack of this coronoid lamella, this stack of parakeratosis, but confirm that you have this dead red. Confirm that you see these dead reds over here. These diskeratotic keratinocytes. That confirms to you that you're not just seeing things, that it really is a true coronoid lamella. All right. And what are we seeing here?
Intraepidermal split.
Okay, there's some sort of, there's a split here. Is it clean or messy?
Messy.
Messy. Okay, so it doesn't look like this is going to be some kind of antibody mediated split, right? Because those are what? Those are clean or messy?
Clean.
Those are clean, right? So what kind of splits are messy? Intraepidermal splits.
Infections.
So what's one thing? Okay, so you can have some intraepidermal splits from infections that are messy. You can see that in certain viral infections. Okay, what else? What pattern are you seeing here?
Spongiosis.
Spongiosis. Can spongiosis give you a messy intraepidermal split?
Oh, probably. Also, yeah.
Absolutely. Absolutely. If there's enough, because why do you have the spongiosis?
Edema.
Edema.
Intercellular edema.
So what happens when the edema outweighs the strength of the desmosomes?
Blister.
Yeah. The desmosomes have given up. We failed. Okay. What else are we seeing here? Okay, let's see. Now here's a good exercise. What's this?
That's a dead red.
That's a dead red. Okay, good. What's this?
It's an eosinophil.
An eosinophil. Good. Be able to differentiate eos from dead reds in the epidermis. That's important. How did you differentiate that?
I guess you could see a little bit of stippling in the
Yes, I
eosinophil.
love
and then
it.
the color.
I love this. Excellent. Yes. Be able to look at the stippling. Look at the common theme. The mast cells. We saw the stippling. The eosinophils. You saw the stippling. Even if this is homogeneous. These you could even see it from. I'll zoom in. I'll force zoom it, but this is not homogeneous. This is stippled. This is an EO. This is becoming a dead red. This is a dead red. And this, you draw it. What's this one here?
Probably an extravasated red blood cell.
Yeah, so you guys know this. Differentiating dead reds, EOs, blood cells. And this?
Another EO.
That's another EO, good. Okay, So, and there's eos in the epidermis over here. You can see them. And there's spongiosis. So what does that mean?
We're in the happy differential.
Yeah, so that limits our differential, doesn't it? So what's our differential now?
Herpes zoster, allergic contact, pemphigus, pemphigoid, IP, EED,
Mhm.
and then I forget what the D is.
When you say EED, what's
Oh, ETOX. Sorry, not EED.
okay, good. ETOX, not EED doesn't have that's not part of the differential. So ETOX, yes. EED, and D's for drug, by the way. Drug can do it too. Good. So you have eosinophilic spongiosis, but remember, you also have what that we pointed out? We just said it.
So can you not just get dyskeratotic cells from like the epidermis getting blown open by all the spongiosis?
So yes, you can, but look at the difference of how it looks. See how there's a lot of eosinophils over here. But when you see the spongiosis, you see that feathering, you see that those types of like, it's almost stretching out the proteins of the cells. And then you almost see a type of homogenization of the cells with each other. That's the type of death you type of see with when the edema becomes like so extreme. That's very different than, for example, over here. And also, by the way, you see dead reds in areas where you don't have that. So look, there's dead reds over here. But the dead reds are not because of the edema just blowing everything up, because they're in the areas of the cells, they're in the areas of the epidermis where it's normal. Or at least there's just spongiosis. There's also something else I want to show you. How many dead reds are here?
3.
3. And what they're concentric. With do you see how like they're whirling together? Like a whirl of dead reds. That's another thing that actually clinches this diagnosis. So eosinophilic spongiosis with dead reds, what's on our mind?
IP.
IP, good. Incontinenti pigmenti, especially when you see this whirling of the dead reds with eosinophilic spongiosis. It's IP until proven otherwise. What stage of IP is this?
The vesicular.
Yeah, bolus, yeah, exactly. This is the vesicular bolus stage of IP. Good. Look how you see. So you already, once you be able to recognize eosinophilic spongiosis, you recognize eosinophilic spongiosis, you have narrowed your differential down immensely. There's only so many things it could be at that point. Go through your happy differential. Once you see that it also has whirling of dead reds, that's IP until proven otherwise of that differential. And what's going on here?
Pseudoepitheliomatous hyperplasia.
Okay, there's acanthosis for sure. What else are we seeing?
Maybe there's dyskeratotic cells in there.
Yes, there are dyskeratotic cells throughout. So dead red, dead red, dead red. Are they whirling?
Yes. So now are we in like verrucous IP?
This is verrucous IP.
They
Yeah.
never would have gotten this if it weren't back to back with the first one, though.
Yes, but well, look, when you see a verrucous lesion with dead reds whirling conspicuously, you have to be able to, and be able to differentiate that from squamous eddies. It's not the same thing as a squamous eddy, which would tell you, if this were squamous eddies, it would tell you what? That it's more likely to be a.
I guess CC.
That would be keratin pearls. But
Oh.
squamous eddies are typically a benign finding found in sebs, yes. Sebs, okay, they irritate, they whirl, the squamous
Right.
work together, but dead reds whirling. When you see dead reds whirling, you have to think of IP. if you're confirming that, hey, these are actually dead keratinocytes and they're whirling, you have areas where they're whirling together, you got to think this is going to be, you have to at least have that under your differential. And you can look and maybe try to find some eosinophils. And in this case, you might be underwhelmed with them. But yes, this is the verrucous stage of IP. And this is, what do we see here?
Epidermal pallor.
Yeah, now that could be, now, okay, so here's a point. Is there epidermal pallor or is there just pallor everywhere?
Looks like pallor everywhere.
There's pallor everywhere. All this collagen is like, this shouldn't be white, right? So you have to adjust, mentally adjust. Like this is a washed out slide, right? So if so you were going to epidermal pallor, and so what were you thinking when you were going epidermal pallor? Where would that lead you?
Probably like zinc deficiency.
Nutritional
like
deficiency
Coxsackie.
or Coxsackie or
like necrot. What was it? The
paralytic
glucagonoma one. Yeah.
Glucagonoma, exactly. So you're going to go in that differential, and you'd be right to do so if you saw the epidermal pallor. I will tell you right now that you can get janky slides on the core. You can. In fact, look, when you guys take your Genderm core, do you get janky codas? Do you get these old photos from AAD where it's all washed out? Of course you do. They show you all these janky photos all the time. Guess what? It's the same thing in dermpath. Just like you can get janky codas, you can get janky slides. This is a janky slide. But you got to adjust. So it's fine. We can work through a janky slide. We just have to mentally adjust. So we're going to say, okay, we're adjusting the pallor in our minds. We're saying, okay, the whole thing is pallor. So it's a little washed out. That's fine. What's this?
Some whirling, and maybe are those squamous eddies?
Well, they are whirling. If they're squamous eddies, they're going to be alive.
And those aren't.
Those are,
Whirling
I don't
dead
see any, in
threads.
fact, I don't see any, yes. So remember, the slide's janky. But how do we know they're dead reds and not squamous eddies? What do these cells have that are alive that these don't?
The nuclei.
Nuclei, exactly. So these are dead reds, even though they're not red. See, you're able to work through a garbage slide. You say, okay, I know there are certain features of dead reds that I could do this while colorblind. You can be a dermatopathologist, even if you have color vision issues. You just adjust. Say, okay, I know that there's whirling keratinocytes, they don't have nuclei. That's whirling dead reds. Whirling dead reds, again, I keep belaboring the point. What do you have to think about?
IP.
IP, exactly. And then what are we seeing true to the name?
Pigment incontinence.
Pigment, what stage of IP is this? What are the IP stages?
Is hyperpigmented.
It's the pigment, it's the
Pigment.
yeah, it's the depigmented stage when the pigment drops out. So there's the vesicular bullous stage, there's the verruca stage, and then we burn out, right? And then we drop out our pigment. So this is the late stage. And as the name implies, this is incontinentia pigmenti. We have our pigment incontinence. So now you know all the stages. By the way, what's the mutation in incontinentia pigmenti?
Nemo.
Nemo, good. Okay. And the pattern is what?
Maybe normal.
Yes, exactly. I love it. Don't be afraid. Have no fear. Do not be afraid to say nothing is here. So yes, minimal change, nothing. So we're going to go through our differential. All right. Organisms in the horn. I don't see any. We didn't lose our granular layer. It's subtle, but it's there. Here's the granular layer. Nothing crazy on the basal layer. Now there is a small amount of superficial perivascular. Right? So let's characterize that a little bit. What kind of cells are they?
Lymphs.
So there's some lymphs. Let me see if I can get a better out of this. They're in the dermal papilla. So there are some lymphs in the dermal papilla, but there are some, like, look at this cell and this cell. Do these look like lymphocytes? What's wrong with lymphs for these cells? And this cell, and this cell.
Oh, they're bio.
Go ahead, wait.
Oh.
You guys are there. You're almost there. I know. I can hear the answer at the tip of the tongue.
Eos?
Okay, so getting there. They're not eos, because eos you would see so close. Why? So why are you saying eos? What made you think you did you? So they're not bilobe nuclei that you see in eos, but there is something that they have that are similar to eos. First of all, why are they not lymphocytes? What's
Are
wrong?
these mast cells?
These are, yes, exactly. These are mast cells, guys. What tipped you off that they're mast cells?
And the stippling. And then
The
I guess
stippling. Recognize the stipple, right? It's not a homogeneous cytoplasm. Dot. There's these tiny little dots. First of all, okay, it can't be lymphocytes because there's way too much cytoplasm for this to be a lymphocyte. We all agree on that. It's not a plasma cell because it's not off to the side. And the thing you have to pick up on here, they do ask this, is can you pick up that these are mast cells? It's a subtle superficial perivascular infiltrate of mast cells. Look for the dermal papilla. They love to also clump a little bit in the dermal papilla, in the vessels of the dermal papilla. But see how they're stippling here. So yes, and you can even see some of them start to become that fried egg appearance. So then what is it then? What is the diagnosis?
TMAP.
TMAP. Yeah. Telangiectasia macularis eruptiva persistens. Very good. Now, again, you're not just going to sign this out. You'll stain it, you'll confirm, you'll get your C kit, CD117, and whatever other lovely mast cell stains that they can ask you. But yes, be able to clue yourself in. So know that TMAP is on your nothing differential. The nothing differential is not nothing. So TMAP, very sparse superficial perivascular infiltrate. Watch out for them being mast cells. Right? You already see your fried egg over here. And here, and here. But really, it's not the fried egg. Really, it's the real clincher is the granularity. Okay. And what are we seeing over here?
There's some cells in the dermis and maybe some effacement of the reedy.
Okay. Cells in the dermis, and when you
Well,
okay,
there's the yolk over there, and then on the top, it's more like pigmented.
okay. So pigment over here. Okay. Now the pigment, this pigment could be it could be normal, it could be abnormal. We haven't decided yet. When you say pigment, are you talking about anything else? Are you talking about this? Are you talking about this?
No, it's just like it sort of looks almost like a lentigo on top. And,
Okay.
But I'm sort of thinking about it also as potentially being part of the entity.
Okay, good.
But
Okay.
I don't know yet.
Well, and what are you seeing over here?
I think I need slightly higher power.
Okay.
It's like squiggly and messed up, and I'm trying to place what it is.
What does it look like?
I mean, it looks like the elastic fibers of PX.
Yeah, it
Does.
looks like PXE kind of. That's
Does.
something.
Yes, it does. I agree. It looks exactly like the last sort of PXE, but what else is there? We're gonna put this all together. What's this?
Something calcified.
It is something calcified. Okay, good. You're recognizing the calcium. Not just the elastic, but there's a nodule of calcium here. And by the way, what's this? Why is there a hole here? What happened?
Like the dermatome did something because of the calcium.
The microtome, yes.
Microtome.
The microtome did, yes. So this is good. You're recognizing that this is an artifact. So what happens, and this is a typical artifact that you find with calcifying conditions. Calcifying conditions, remember, you have your blade that's cutting the tissue. That the calcium is hard. It can grab the blade, it can nick the blade, and the blade, what happens when you get that, the blade will take the calcium and it will drag the calcium through the tissue. So the calcium gets caught on your microtome blade. There's a nick in the microtome blade, a piece of calcium gets caught in it, and it will just drag it right through and destroy your tissue wherever it is. However, it can be a little useful hint because in more subtle cases where you're looking for calcium, you can see a little itty bitty dragger, and then you follow the yellow brick road and look where you end up. There's your calcium. See that? It's obvious here, but in more subtle cases, you can actually use this artifact to your benefit. If you can you can use it to find the calcium at the end of the yellow brick road. So we have a number of things here. We have nodules, these nodules of calcium. We have what looks like PXE. We have this calcific elastosis. Okay. And then we have something that looks like, as was said, potentially a lentigo. How are we putting this all together? What if I gave you the site? What if I told you this was around the belly button?
I thought that it looked the perforating calcific elastosis.
Yes.
But what it doesn't, it's not perforating.
Well, you don't have to see, you don't have to see it you don't have to see it perforating, but I'll tell you what can give it away. So I already gave you the site. You don't have to have the exact cut of any perforating, of any of it perforating. But you can see that there's calcified elastosis. You can see that there's nodules. And by the way, what's going on here? You picked up on this pigment. Why is that?
Doesn't it usually happen in like African American?
Yes.
Like
Yes, exactly. Skin of color, guys. How do you, can we tell Fitzpatrick skin types on dermpath? Can we? Of
Apparently.
course we can. Of course I can. Why wouldn't I? Look, how do you tell Fitzpatrick skin type clinically? The same way you do it on dermpath. You look at the epidermis, right? Clinically, you're going to look at the patient's epidermis. On path, I'm going to look at the patient's epidermis, right? Look how pigmented this is. Do you think this is Fitzpatrick 1, 2? And it's throughout. This is normal. This is the normal patient skin pigmentation. This is a 5, 6 easily. So we put it all together. You have your hint of the patient demographic. You have your PX, your calcified elastic fibers. You have your nodules of calcium. You have to be thinking perforated calcific elastolysis. And if you get the site that it's a belly button, it's all clinched for you. Okay. What do we got here?
It looks like a hypertrophic horn.
Okay, let's be specific because we don't want to just jump and call it a horn. or cutaneous horn. I didn't say cutaneous horn, you said hypertrophic horn, but what's the name for that? In dermpath, what do we say? Don't overthink it. It's simple.
Parakeratosis.
Yeah, hyperkeratosis.
Well, like I'm not sure if it's parakeratotic or just compact ortho.
Yeah, okay, so you can say this could be compact ortho, parakeratosis, but some kind of hyperkeratosis. It could be a parakeratosis, it could be a compact ortho, but fine. There's a lot of stratum corneum here. Fine. What else are we saying? See if this is better. It is better. Anything else?
Is this the buckshotting in the granular layer?
Yes.
HK?
Shotgun to the granular layer, right? Look at the vacuoles. Where are all these vacuoles? They're not in the basal layer. Not really much.
Granular.
The granular layer. We have vacuolated our granular layer. And there's these little condensations that you can see here and here and here. These are called tonofilaments. Those are clumps of protein, a type of protein. And the problem here is what mutation?
Keratin 1 and 10, I think.
Keratin 1 and 10. What's your diagnosis?
EHK.
EHK. Where do we most commonly see this in dermpath? As what kind of finding?
Incidental.
Incidental. Yes. The most common way we see EHK is just an incidental mutation. That means nothing. It's just you see you get some sort of diagnosis and oh, there's some incidental EHK. Now, but if there's a baby with a colloidal membrane, what are we worried about? And this is everywhere in the baby's skin.
Epidermolytic ichthyosis.
Right, congenital ball. Go ahead, Ebola congenital ball ichthyosiform erythroderma. Yes, very good. Okay, so don't just look at just because you have EHK doesn't mean it's from a colloidal baby where you're going to be getting both CIE. Most common thing, we just see it in everyone. We see it we see it once in a while. Occasionally, there's some incidental keratin 110 mutation. That's all. But yes, know the shotgun to the granular layer. That's a very easy giveaway. And then you have these condensed tonofilaments that you see over here. You have to be thinking about EHK. All right. Who sees it?
See the trapped eccrine glands, the square biopsy.
Okay, so that you're thinking it. Well, I don't know. Could be. But what else is there?
I feel like I need slightly higher power, but I'm thinking about ochronosis.
Yes, you did not need high. I don't know why I gave it to you.
Well, I couldn't tell the color.
Okay.
Okay, now I can see it.
There, yes. They look like what? Bananas, right?
Yeah, that's why I needed the color.
There you go. Okay, so ochronosis. So what? Okay, now what are the ways we can get ochronosis?
Alkaptonuria or like exogenous ochronosis from hydroquinone.
Good. So you got to know about exogenous ochronosis. You got to know about the endogenous forms of ochronosis, alkaptonuria, because of homogentic acid oxidase. So it leads to accumulation of homogentic acid. Exactly. So, but yes, this is the give me. They're going to give you this. You're going to be able to get ochronosis in 2 seconds. Always make use of your give me's on the dermpath core. This is a timed exam, and you're going to have around 20, 25, maybe even 30 slides where you're driving it yourself. All right. So you want to make sure that you take your give me's as a time builder. And you use those give me's to work through the more difficult, challenging cases, because there are not every one of these cases is going to take you, the average amount of time. the way your core exam is made, they're going to give you cases where they expect you to get it in 2 seconds and move on to the next question. And that is going to build up your time for cases where you're really going to have to think and work through it for like 5 minutes. Right? So don't expect to have the same amount of time in each question. But this is an example of a time builder saver question. You're going to look at this. I know the answer. Next. You guys know this.
I'm thinking EDV, but I'm not confident.
Why are you not confident? You're so right. Every time you say you're thinking of something, it's the right answer. So we know what to do on the exam, right? You just go with your gut. If you're thinking of something, just put it down. You're dead on. Yes. EDV. Walk me through it. What's going on?
They're like the keratinocytes are like, I guess the word is like slate gray, or they're like blue gray.
Yeah, they're the slate blue gray.
Like dilated out.
You can see this exactly, and they're throughout. It's from top to bottom, except maybe the basal layer. This like, and what is the? So this is like that type of weird type of, so that type of weird slate gray look that just takes up and look. Compare that to normal. Like this is your normal epidermis over here, right? And now you can see it's just being replaced by these large. So there's large epithelioid slate gray nuclei. And then what are your common mutations for EDV?
EVER1 and EVER2.
EVER1 and EVER2, exactly. So epidermal dysplasia bruciformis. You know it. You already know it. Be confident. Okay. I don't blame anyone who's not confident for this one, though. This is if you don't get this one, don't feel bad. But walk me through it. Just describe. This is like the challenge. So on your exam, there's going to be some questions that are just there to set the curve. Don't feel discouraged by them. They're doing this for statistical purposes. This is a type of question that they would give you just to set the curve. Be like, okay, we need people to get a question wrong. Just so we can get that one weird dermpath nerd who gets it right, and so we can have the statistics work out. But what I would expect you to do is be able to describe things for me. So walk me through it.
There's like right there, like a collection of like looks like lymphocytes, but it could be other cells intermixed.
Okay.
There's compact parakeratosis
Good.
on top. The reedy is effaced.
Good. So you've actually noticed what you've done now. You may not know this, and this is a rare condition, but you've accurately described all the features, and probably if you typed into Google everything that you described, you'd get the condition come up. I wouldn't even be surprised. But yes, look at the degree of thickness of the epidermis where you don't have that infiltrate, right? This is normal. What does it look like over here? How thick is the epidermis over here compared to there?
More atrophic.
More atrophic. There's atrophy of the epidermis, and it's only at the area of the infiltrate, and only the parakeratosis is only at the area of the atrophic epidermis. Same thing over here. Normal thickness, it's atrophic. Infiltrate, stacked para, but the stacked para is only at the area of the atrophic epidermis where the infiltrate is. When you see those three findings, there is a condition that you have to think about, or well, it's a rare condition. It's called hyperkeratosis lenticularis perstans. Has anyone heard of that? Does anyone know what the other name for that is? The other name for it is Flagel's disease. Hyperkeratosis lenticularis perstans. So the reason I'm mentioning this is not to discourage anyone. The reason I'm mentioning this is that you'll have a weird question. There's going to be you can expect, there's 75 questions on your exam. Expect 5 of them to be really weird questions like this, like these very odd things that you may have not heard of. That's okay. They're just curve setting questions. Don't get discouraged and just move on. Right? If you want to be like that superstar, you can be the superstar, but you expect 5 of them to be the weird ones that may even be experimental. And I remember that even on my course, there were some weird questions that were just like these really new findings, these novel things. So for example, let me ask you, where is melanin stored in keratinocytes? Normally, I'm not talking about like after sun exposure, like where is it stored?
Melanosomes.
Yeah, well, so melanosomes, okay. It's but I'm talking about in keratinocytes, not in melanocytes. So when the melanocytes gives its melanin to the keratinocytes, where does the keratinocyte store it? So this was actually a question, and this was a weird new novel finding. The keratinocytes actually store their melanin from melanocytes in a type of lysosome called a melanokerosome. It's a modified type of lysosome that does not degrade the melanin. And apparently this has just recently been discovered. This is like a novel finding. And that was on the dermpath course. And no one knew it. Everyone hated the question. Everyone's like, what is going on? Why did they ask this? I looked that up 20 minutes just to get this answer to this question. It turns out that they're just asking this novel finding. It's just a curve setting question. Don't be discouraged. But yes, you get these really weird questions. And that question didn't come up again, by the way. On the next exams, I think they dropped that question. Because a lot of they go over the questions and how many, I think too many people got it wrong. But anyway, what are we seeing here?
Square biopsy sign.
Yeah, this is a rectangular square, as square as you can get. All right, so what are we thinking about when we see this obvious type of square biopsy sign?
Morphea, scleroderma.
Some sort of sclerotic condition. Yes, exactly. Okay. What are we going to look for morphea, if this is morphea?
Like trapped eccrine glands, maybe some plasma cells,
Mm-hmm.
sites.
Okay. So the eccrine, you mentioned the eccrine glands. So in morphea, what happens to the eccrine glands?
They get trapped.
Yeah, trapped in, and then what else happens? Like what do eccrine glands normally have a little bit of?
Fat.
Fat. Yes, they normally have a little bit of fat. So what happens in morphea? Well, let's take a look. Is there any of it over here? Here's your eccrine gland.
You lose the fat.
You lose it. Okay, good. So you lose, so a couple of things you see in morphea. In fact, we're going to get to other examples of morphea, but this is morphea or scleroderma. So you will lose your periacrine fat. You will lose, so that's another thing is fat trapping. There's also, if you had the subcutis here, you can see a very line, like a demarcation between the fat and the collagen itself. And remember, this is a sclerosing condition, not really a fibrosing condition. What's the difference between sclerosing and fibrosing? The cells. Tell me about this. How many, do you guys see an increase or decrease of cells?
Decrease.
Decrease, yeah. So this is a sclerosing condition. And this is going to be morphea. We're going to go through other examples of this. And what is here's another thing they can ask. What is a loss? What staining is typically lost in morphea?
CD34.
CD34. Yeah. There's a geographic loss of CD34 staining in morphea. And usually if it's in early cases of morphia, the CD34 loss is more pronounced in the reticular dermis than it is in the papillary dermis. So you see this geographic loss of CD34 staining in the reticular dermis more than the papillary dermis. In later stages of morphia, you can see it throughout. But yes, good job. You have to know that. CD34 loss in morphia. What are we seeing here? All right, I'm not going to zoom in because we can name some things that we're seeing at low power.
Is that a Gren zone?
Okay, close.
Uh,
It's
yeah.
it's like a Gren zone, but what? Tell me about the color.
Oh, it's pale. Is this the red, white, and blue?
Ah, yeah. What color is this?
Red,
What color is this?
white,
What color is this?
blue.
What does that make you think of?
LSNA.
LSNA. Okay, so why is that white over here? Why is it white?
But is it edema or
Yeah, papillary dermal edema. You got to know what papillary dermal edema looks like. There's a number of things that are going to be in this family that you have a differential. I mean, just off the top of the head, like what are some other things that have papillary dermal edema?
Sweets, PMLE.
Good. Sweets, PMLE, radiation dermatitis, LSNA. These are all things that have papillary dermal edema. So we clearly have our findings of LSNA. And by the way, what side are we on? I mean, we gave the diagnosis away, but let's look at the features here. What are all of these? What's this structure and this and this?
Muscle?
Smooth muscle.
muscle.
Yes. How much smooth muscle is there? It's everywhere. So there's a ton of smooth muscle. What does that tell you? And what is this, by the way?
eccrine glands?
Is it eccrine? What kind of
Oh, it's snouting, so apocrine.
apocrine? Yes, these are apocrine glands. And here as well. So if these are apocrine glands and there's a bunch of smooth muscle, what does that tell you about the site? Where would you narrow your sights to?
Genital site?
Yeah, anogenital. Probably anogenital. Exactly. Now, does that go with our diagnosis?
Yep.
Yeah, it does. Exactly. It all works out. Let's not miss anything, though. What else is there?
Spongiosis?
Spongiosis. Yes. And you'll notice there's not just a band here, but there's also clumps of lymphocytes around vessels. So you have what kind of mixed pattern? Superficial perivascular with spongiosis? What does that tell you? Like what is the most common entity we see when we see superficial perivascular dermatitis with spongiosis? What are we thinking of?
Spongiatic dermatitis?
Yeah, some spongiotic dermatitis, and commonly we see that in things like atopic dermatitis, contact. So there's a differential for it, but notice that this is not just LSNA, because if it looked like this, it would just be LSNA. There's more here though, right? So there's an overlap. This patient has two things. This patient had LSNA, but guess what? They also had atopic dermatitis. And in this case, they have LSNA on top of their atopic dermatitis. So what do you think this patient's experiencing?
Severe itch.
One of the worst itches ever. Exactly. Poor patient. All right. What are we seeing here?
Like a lot of nothing, but maybe in the lower dermis more hypercellularity.
Okay,
Maybe that's mucin in the like mid dermis.
okay, let's take a look now. Could be, could be that the slide is faded, because look at the color of our epi. But also it could maybe not be slide is faded. Maybe there's something about this. There is a band, I agree. So there's this band of lymphocytes. And maybe some other cells, but mostly lymphocytes, I agree. But by the way, what color is this?
Red,
What color is this?
white,
What color is this?
blue,
What does that make you think of?
another LSNA.
Okay, but why is this so different? What's the problem?
The blue is very low.
Blue is very low. It's almost like it started up here and worked its way down here. Why is it almost like that? Because it is that. So LSNA, you can see that concomitant with what other condition? In fact, look at the shape of this biopsy. Look what it's starting to form.
This the overlap with morphia.
Yes. In fact, many times you can see LSNA and morphia in the same biopsy. LSNA, after this is all done, the band of lymphocytes went and went and went, you can start seeing something that looks like morphia here. But yes, this is that LSNA morphia overlap, and you have to know that. Here's your papillary dermal edema. But as this thing gets let go, aside from just squamous cell carcinomas that can develop and untreated conditions, you can often see LSNA with features of morphia in the same biopsy. Treat it early. What are we seeing here? Now this is good. I like this biopsy. This is when you get a biopsy of a nice inflammatory condition. This is what I love to see. Whoever did this biopsy, A+. They didn't just do the biopsy, they pushed the plastic into the patient. They wanted to get a really deep biopsy here. So tell me what's going on. What's striking you?
The fat is very, it's kind of like herniated. I don't know if that's the right word, but
Are you thinking of herniated fat? Well, I don't know if this is herniated fat over here. It's certainly not going up to the papillary dermis. And in terms of the fat over here, this fat over here, I mean, there's some procedural effect over here. I'll tell you that it's what's throwing you off. We can find another example where the fat's more preserved, but there is some artifact here. There's some procedural effect that's happening, but there's something else that should really be just striking to you here. Like, what's deep? Like, what's below? Let's go through the layers. Okay, we have our epidermis, we have our papillary dermis, we have our reticular dermis, we have our subcutaneous fat, and what do we have after that? Because I mean, look, yeah, because look, someone decided. You gotta be thinking, like, why would someone do a biopsy this deep? Someone had at some point decided that I need to get all the way down, probably even down to the muscle. Right? We don't just do a biopsy this deep. They either do a double punch or that you can even push the plastic of your punch biopsy into the patient. And I've done that for some cases. When I was on call and I had calciphylaxis, you need to get down to the sub-Q, and sometimes the reticular dermis can be so thick in these patients that I would just tell the patient, listen, I am going to be doing a deep biopsy. I'll push the plastic into the patient. You don't have to stop at the hub when you're doing your punch biopsy. There's no organ in the human body that can't be reached with a 4mm punch and a strong enough resident willing to push it in. Okay? You can get anywhere. And that's what I do. I push the plastic straight through the patient. And you can get a nice core of a biopsy. So someone decided that they need to get fascia here. That's important. Does this look like normal fascia? I mean, there's a whole bunch of inflammation here. It's thick, homogenized, collagenous fascia.
No, not normal.
Yeah, and it also has signs of chronic inflammation. I mean, we see what are these cells over here.
Lymphocytes.
These cells? Here. What cell is this?
Sorry, I think my screen was just lagging. Those
Oh, okay.
neutrophils.
Neutrophils. Look,
Macrophages.
cytoplasm. And then I don't know if you're still lagging, but maybe there's a delay, but cytoplasm and then the nuclei to the side. Everyone see that?
Plasma.
Yeah, plasma cell. You guys see this, right? What I'm drawing? Are we caught up? Is there a lag? I want to make sure you're seeing what I'm seeing. Okay.
Yeah.
Good. So you're seeing plasma cells. So there's some signs of chronic inflammation in this fashion. So there's two things that this could be. What's our differential? By the way, what other cell is there?
Those are EOs. So
They are
I'm thinking eosinophilic fasciitis.
Okay. Now, so yes. Okay. Eosinophilic fasciitis. What else could this be? When you see this type of sclerosis this deep, there's one thing else on the differential you should be thinking. So we went through morphia. Is there a type of morphia that goes deep?
Deep morphia.
Deep morphia, morphia.
Profunda. But then the rest of it would look like morphia too, right?
You can have a type of deep morphia profunda that
Oh.
yeah, you can in fact so I'll tell you this. I'll tell you this right now. Morphia profunda and eosinophilic fasciitis are very hard to differentiate from each other. They can have a lot of overlapping clinical and histologic features. And by the way, this is something I didn't realize, but 40%, I know it now, 40% of people with eosinophilic fasciitis, guess what they also have? Some sort of morphia, not necessarily morphia profunda, but they also have some sort of morphia. Crazy. Eosinophilic fasciitis. Let me just go through a couple things. First off, you picked up on the eosinophils. Do you need to see eosinophils for eosinophilic fasciitis?
No.
Yeah, and where are these eosinophils coming from? Is that really even the problem here? Is it like, the eosinophils are attacking the fascia? Is that what's going on? Is that why you're seeing them here?
I have peripheral eosinophilia.
Good. It's in the peripheral blood. And I'll prove this to you right now. So it's not like the plasma cells or the lymphocytes here that you're seeing that really are part of this pathogenesis of thickening the fascia and sclerosing it. If you see the eosinophils, like here, you see it. The eosinophils are here. For the eosinophilic fasciitis, you know why you see the eosinophils here? This is a bloody biopsy. I'll prove it to you right now. Look at all this blood. What cells are here?
EOs.
EOs. It's based, so you don't see any nuclei because red blood cells have nuclei, but when you do see, there are cells that have nuclei and you see the stippling. So you're basically getting a peripheral blood smear and a tissue biopsy at the same time. You get 2 for 1 here. You get to see all the eosinophils that are in the blood just because of the messy clinician. Usually you get annoyed at the clinician, but in this case it's actually helpful because I get to see all the eosinophils from this bloody biopsy. All this procedural blood has all of these EOs. Does anyone know the cutoff, criteria cutoff proposed for eosinophilic fasciitis, with peripheral eosinophilia, how much it needs to be? 0.5 times 10 to the power of 9 absolute eosinophils per liter. So peripheral eosinophil, that's one differentiator of eosinophilic fasciitis versus morphia. Is there anything clinically we can look for eosinophilic fasciitis? You guys ever hear the groove sign? So what happens when your veins forget to take their Prozac?
They get depressed.
Yeah, when your veins forget to take their Prozac, they become depressed. Exactly. So you see this depression where the vein should be. These linear depressions where the veins are coursing through and they're accentuated. You can even, and if you elevate, there's a trick you can do. You can take the patient's limb and you can elevate it. And then what's happening there is you're making the vein have less hydrostatic pressure, and that groove sign gets accentuated. So it heightens the difference between how bound down that vein is because of all this that sclerosing of the eosinophilic fasciitis, and you're accentuating that by decreasing the hydrostatic pressure of the vein, and then you see this groove sign even more pronounced when you elevate it. So that's a little trick you can do that's for eosinophilic fasciitis clinically. But yes, eosinophilic fasciitis, morphia profunda, very similar. By the way, in eosinophilic fasciitis, are you worried about anything? Or are you just going to let this go? Is there a workup you have to do? So I will tell you that 5 to 10% of patients with eosinophilic fasciitis have a malignancy. And it's usually not a solid malignancy. It's usually some sort of hematogenous malignancy. So that's one thing you have to, so there is a workup that you do have to get some sort of workup to rule that out. Now, this is what you're talking about. Now, this case, it's easier because as was mentioned, so you're going to get this and we're going to go through all the signs, but this, what are you seeing here?
That's fat.
This is fat. Yep. And this is,
Fascia.
and this is
Muscle.
muscle. So again, and what kind of muscle is it?
Skeletal.
Skeletal muscle. Yes. So again, and this, by the way, this is not a double punch. I'll stress the point. It's not a double punch. You don't have to do a double punch to do this. You can just go through the hub and push the plastic right to the patient. You can get anywhere you want to go. You can get as deep as biopsy as you want. But someone decided they wanted to get that deep. Now, in this case, it's a little bit easier because you can see this over here, not just this. And you see all the other signs of this entity. Let's just go through it. You see a band of inflammation. And in this band of inflammation, we see something that we do typically see in this entity, which are what kind of cells?
I'm like leaning plasma cells. They're a little
Plasma
bit
cells.
red, like, but they have features of plasma cells.
Plasma cells. Good. No, they're to the side. Every time you start your answer by saying, I'm thinking of, just so you know, you're correct. Okay.
This is why I don't check my test answers ever.
Yes, please don't. Never go back. I will tell you right now, never go back on your answers unless you're like 100% sure. When you say, I think, you're right. Just, that's a theme I've noticed with you. So yes. Okay, plasma cells. Okay, sclerosis, plasma cells bands. And by the way, this is the line sign that people talk about. There's this very sharp demarcation between the sclerosis and the fat. That's one thing. And then there are these glands that are trapped. Eccrine gland trapping, line sign, plasma cell infiltrate. What is this all telling you?
Morphia.
Yeah. And morphia is going deep in this case. It's
Morphia profunda.
profunda. Okay. Where are we?
Somewhere with cartilage, so it's the nose or the ear, and I see lots of hairs, so I think we're on the ear.
Okay, good. Excellent. That's exactly right. If this were the nose, what would you expect besides the cartilage that
More
you're
sebaceous glands.
good? Yes. So know how to differentiate the nose from the ear. In both cases, you can see cartilage. That's fine. But difference is the ear is more pronounced with hair follicles over sebaceous glands. The nose will have a more predominance of sebaceous glands over hair follicles. Okay, good. So what's going on with the ear?
There's,
Oh, go ahead, Jenny.
no, you got it.
I was gonna say I would need to zoom in, but I think the cartilage may be inflamed on the left there, and then there's sort of like a cavity within the cartilage that has stuff in it.
Okay.
Maybe it's not inflamed. It's
There
just
is some amount, yeah, okay. So there's some amount, well, you second guessed yourself and you're right on the second guess. Okay. Wait a minute. What's going on? All right. So there is some inflammation. It's not that inflamed though, but look at this, but you pointed out this. What is going on here?
there's like a cavity filled with junk.
Yes, all this goo, it's homogenized. This homogenized basophilic material. What does that
So
tell
is
you?
like, is this going to be the pseudocyst of the auricle
Yeah,
or something like that?
Yes, it is something like that. It is that. Pseudocyst of the auricle. Yes, you see, and you can see it. This is a very clear case. You see the cartilage. And in fact, you see some loss of the basophilia of the cartilage because the cartilage is not doing so well. So what's going on? Why do people get pseudocysts of the auricle?
Trauma.
And what do they? Yeah, trauma. And what do they? And yeah, trauma. And if you can drain these. It looks like you put a needle in and you drain it. It's like this oily, really oily, gooey substance that comes out. And what ends up happening? Like, what's the end stage here to these ears? I'll show you. It's an old picture. This is me. This is my friend. Anyone recognize this guy? This is James Wilkes. What does he do for a living? Look at his ear.
I'm guessing he boxes.
Yeah, he's a UFC fighter. Exactly. How'd you know that? What's wrong with his ear?
Is that the cauliflower ear?
Cauliflower ear. Yes. He's got a collar. That's the end stage for all these pseudocysts of the auricle, by the way. You get this repetitive trauma. So they go into the headlocks, punches to the ear. You see this in wrestlers. You see this in boxers. You can see it in UFC fighters. This repetitive trauma to the ear. That end stage is the cauliflower ear. These can rupture. These can it's not as strong. The ears are not as strong as they once were. But yes, that's what they end up looking like. By the way, what's going on with my ear? What's going on? What's my earlobe?
You have an attached earlobe or
Attached earlobe. What's it? Autosomal recessive? I forget what proportion of the population has it, but yes. Good. Where are we here?
Cartilage again.
Cartilage again. Okay. And what's going on here?
There's inflammation around the cartilage.
Yes. Right. Compare that to the pseudocyst of the auricle, right? Not a whole lot of inflammation. This is just trauma. This is inflammation, right? Now, tell me about the color of the cartilage. So the cartilage when we think of cartilage, we typically think of what color?
Purple.
Yeah, blue. It's basophilic. Now you see some basophilia, but there's a loss of basophilia. Is the loss of basophilia closer or away from the inflammation?
Close.
Close, yeah. So you can make sense. Like where the inflammation is, you see the loss of basophilia of the cartilage. The inflammation is attacking the cartilage. It's very simple. That all goes with what?
Relapsing polychondritis.
Relapsing polychondritis, exactly. Very good. What's this? What does it have the shape of? All right,
I'm
ear.
gonna say it's we got cartilage and it's like really kind of like pedunculated. I'm gonna go out on a limb and say that if they removed this much of it, it's gonna be an accessory tragus.
Okay, so that's one item on the differential. So this could be, so yes, totally could be an accessory tragus, but so at the very least, so you said ear and not nose. Good. Ear and not, so this is something ear. Maybe it's an accessory tragus, maybe a large one. But let's look through the whole thing. So just like we would expect, this cartilage is pretty healthy. This is what normal cartilage look like. It's nicely basophilic. There's no inflammation around it. There's no pseudocysts I'm seeing. And much like an ear and not a nose, there's a lot of these vellus hairs, and there's not a whole lot of predominance of sebaceous glands. What happened here?
Ulcer.
There's an ulcer. Okay,
Is this CNH?
it is CNH.
Why did there's so much removed?
I
There's so
know.
much
We'll talk
cartilage.
about it. But why, before we talk about that, why is it CNH? What are the key findings of CNH? What's this? What color is this? This material.
It's basophilic.
Yeah, it's like purple. There's a purple deposit over here. It's also subtle, but it's here too. You can see it above this degenerated cartilage. This basophilic material to the point where it's purple. What do you guys think that is?
Is that like the necrotic cartilage?
So the necrotic cartilage, it's not necrotic cartilage. Necrotic cartilage, this is basically closer to necrotic cartilage. In necrotic cartilage, you see this eosinophilia, loss of the lacuna of the chondrocytes, and then you'll see loss of the basophilia of the cartilage. This is a fibrin deposit. It's subtle in this case, but it's there. This purple material is fibrin. That's one thing I want you to look for CNH. And in fact, I don't even want you to look for the cartilage in CNH because they have asked, and they will ask, potentially, CNH without the cartilage, and you'll have to be able to know it's CNH. So we're going to go through that. You got the ulcer. Everyone sees this as an ulcer. There's a loss of epidermis. Pick up on the fibrin deposits. This purple material over here that's depositing, that's fibrin. And then what's this? What's going on here? What are these?
Like increased vascularity?
Yes,
blood
these are
vessels,
vessels. And we know they're, how do we know they're vessels?
lined by a single layer.
Yeah, they have an endothelium, of course. They're endothelial cells. So these are vessels, and they're dilated. To the left of the ulcer, are there also dilated vessels to the right of the ulcer? Or to the left of the ulcer, whichever way you're looking at it? Here, and here, and here, and here.
Yes.
Yes. So flanking the ulcer are these dilated vessels. Why is that happening? Think about what CNH is. What is CNH? What causes it?
Like pressure
Pressure. What happens when you put too much pressure?
causes inflammation. I guess that's with dilating the vessels and then eventual ulceration.
Yeah, it's an ischemia issue. When you put pressure, you're compressing the blood vessels, right? You're giving a chronic ischemic change to a part of your ear. A part of the ear which doesn't, with cartilage that doesn't really have the most robust blood supply in the first place. That's the etiology of CNH. And so what happens is you get this reactive change. You have these blood vessels that are trying to counteract that. They're trying to say, no, please get the blood back in. And so they're dilating. That's the thing I want you to focus on for CNH. Ulcer, fibrin deposit, you even see that here. Ulcer, fibrin, flanking of the ulcer, dilated blood vessels. They can ask you CNH without any cartilage. They can give you a question and it's just this, guys. That's all the slide is. And you're expected to get CNH from that. Ulcer, fibrin, dilated vessels, CNH. If they're nice, and I've seen it both ways, I've seen them give it. So remember, there's the give me question. Here are your points. Take the points and move on to the harder question. That's when they're going to give you this. This is the give me question. They're going to show you the cartilage. They're going to show you the ulcer. You're already going to know it's CNH. But they can also, and they have just done this. And you're expected to get CNH just by seeing the ulcer, the fibrin, and the reactive blood vessels. And you're expected to put that all together and say, okay, there is a type of ulcer that has fibrin deposits and also has this reactive ischemic change that's trying to counteract the repetitive ischemia. That's CNH. You're responsible for both. So why is it so large? Well, how do we treat CNH? What are all the ways we can treat it?
Surgical.
Before we get to, you're not going to start surgical excision, but yes, that's one of the ways. So what are you going to start first?
Remove the pressure.
Yeah, behavioral changes. You can give them a donut pill. Okay, it didn't work. Patient comes back. What are you going to do then? You're going to work your way up. You're going to you may inject it, you may try to freeze it, you may try to shave it. But yes, you're right. Ultimately, the ultimate end stage treatment here is just to surgically do a wedge excision, which is what this is. This is a wedge. This is a big old wedge excision of CNH. Crazy slide. All right. What's going on here?
There's like this homogeneous pink material that's getting
Yes.
fissured.
Yeah. It's almost like these elastin fibers are morphing into this collagenous material with fissuring. I agree. That's important. This hyalinized material that fissures. What are we thinking?
I always get like colloid milium and lipoid proteinosis confused.
Well, you know
One of
what?
the two.
We're going to go through them then. Okay. So let's look at this one. Which one has the fissuring? Which one just has the hyalinized material that's in a clumps and fissures?
I think that's colloid milium.
Yes. Notice how every time everyone says I think, they're right. I think it's this. That's the right answer. Good. Click that on the exam. Similarly, we have this biopsy. First of all, what do we see? Much like the previous biopsy, there's an expansion of these reedy ridges. They're expanded here too. All these papillae are pushed up because there's something there. A hyalinized material. First of all, is there fissuring of the hyalinized material?
No.
No. They're wrapping around something instead. What are they wrapping around? Almost like an onion skin fibrosis that you can see in like granuloma faciale, erythema levatum diutinum, but it's not the same type of onion skinning fibrosis. It's this hyalinized material around certain vessels. And also, let's look at the deeper component. What's around these eccrine glands?
More hyalinized
Or
material.
hyalinized material. Yes. So it's not just superficial, it's going everywhere. It's more pronounced that you can see it superficial, but even deep, there's hyalinized material here. So which one is this?
Lipoid proteinosis.
This is lipoid proteinosis. And the first sign of lipoid proteinosis is?
Horse cry.
It's cry, yes. Because it's getting everywhere. It also gets on the vocal cords.
So why is the previous one not, I guess, like nodular amyloid? That was the other thing I get
That's a
confused
very
with.
good question. Why is it not at nodular amyloid? Well, what is this? First of all, nodular amyloidosis doesn't have this type of fissuring. Also, the nodules are made up of the components that are not hyalinized in this way. You see the way, the pattern here is that you're looking at this deposit of material that's pushing up against this superficial papillary dermis into the spreading out the rete. This isn't a nodule. This isn't like a subcutaneous nodule the way you see nodular amyloidosis. By the way, in nodular amyloidosis, what type of amyloid is it? If this were nodular amyloidosis?
AA.
Is it AA or AL?
Sorry, AL.
It's AL. Okay. What's AA? Which ones are those? Does anyone know?
This like the secondary amyloid systemic
Or systemic ones. And what about the amyloidosis that you get from in renal patients that are on dialysis? Beta 2 microglobulin. Okay, but now to answer the question, there's no nodule down here. So first of all, if this were amyloidosis, it would be an amyloidosis that is pushing up against the rete, and so it wouldn't, your differential wouldn't be nodular amyloidosis. What amyloidosis would it be if this were amyloidosis?
either macular or lichen.
Yeah, more likely which one?
Lichen.
Lichen. So if this were an amyloidosis, it wouldn't be nodular. Nodular, you would see like a big nodule over here, and it wouldn't just be small nodules, smaller nodules that are pushing up against the superficial papillary dermis. So you could have a differential of lichen amyloidosis versus colloid milium. That's fine. And let's go through that. What are you seeing here?
Same type of like amorphous
Mhm.
pink appearing material in like the papillary dermis only.
Yeah. And now look at the amorphous material. What are they resembling?
Keratinocytes.
Keratinus, that's the key. That's the answer to the question, by the way. Look at how, and you can see this here too. What's this? You see the amorphous material over here?
Yeah, same idea.
Same idea. Is it the same size as a keratinocyte? More or less?
Yeah.
Yes.
Is that a coincidence?
No.
No, it's not. So this is, all right, so this, what's the diagnosis here? Let's just go through it quick
This is
to refresh that. This is what? Very small. There's very little lichenification. So
yeah.
You said it. What is it?
Amyloid.
Macular amyloidosis. And this same story, resembling the keratinocytes, but it's larger, pushing out into the rete, and there is lichenification. There is acanthosis. So this is lichen amyloid. Okay. Now, in the case of colloid milium, does the homogenized material, are they the size of a keratinocyte?
No.
No, they're huge. And there is fissuring, but the size the separations of these nodules that are separated by the fissuring are massive compared to a keratinocyte. These are not coincidences. In the case of lichen amyloidosis and nodular amyloidosis, you have these amorphous materials that are the size of keratinocytes when you look at how the fissures separate them. The reason for that is because they were keratinocytes and they died. And they became the amorphous material that keratinocytes had, which is why the amyloid is what?
Keratin.
Keratin.
Is that what you're?
Yes, exactly. The keratinocytes died and they have the amyloid that came out of it, which is just keratin, guys. That's all it is. This is keratin. And then macular amyloidosis is
Also keratin.
also keratin. Good. That's also keratin. This is not light chain amyloidosis. This is just nodular amyloidosis and macular amyloidosis. These are just keratin. And it's not a coincidence that the size of the amorphous material resembles the size of the keratinocytes. And this is
I see it perforating out. Is this the collagen perforating out? So like one of
Good.
those
good. Yes. So reactive perforating collagenoses. And how did you know that it's first of all, how do you know it's collagen versus elastin?
the color.
Okay, so I will tell you.
Zero.
So that's fine. You can look at the color. They're thick. The collagen can be thicker than the elastin fibers. That's okay. Sometimes you can see elastin fibers in elastosis perforans perfringinosa that can look sort of similar to collagen. But so I don't want you to just focus on the color of the fibers themselves. So fibers themselves are good for just saying, hey, this is a perforating disorder. I can see it I can see the fibers in the dermis. I can see them literally coming out, right? They're perforating. Something's perforating. But what is a big difference between, say, reactive perforating collagenoses versus elastosis perforating supergenosa in terms of the channel that it's perforating through? How would you describe the channel? Is it simple, broad, or is it tortuous and narrow?
It looks simple and broad.
Simple, broad. Exactly. This is a simple, broad channel. Here's dermis. Here's out of the dermis. Very cool. Very simple. Very straightforward. Collagenous perforating disorders love that. They love a very simple perforating channel. But this, what does this look like?
Small dilated or tortuous.
Tortuous. This is a tortuous channel. It's very tortuous. You can see, so you can see there's fibers, right? We can all see there's fibers, but notice there is some red fibers here too, right? It could be tricky, but the key here is the tortuosity. We have a channel here. This channel decided either to go into the page or out of the page and then come back over here to rejoin and then take another turn before going out and perforating through here. That's the difference. So this is what?
EPS.
EPS. That's elastosis perforans supergenosa. Okay. That is the key. The key is, so it could be hard. I mean, look, you can stain it. You can always cheat. I agree. Cheat. You can find, if you have the ability to cheat, you can cheat. You're going to order your stains. However, you should be able to tell what this is just really based on the tortuosity of the channel. EPS has a very tortuous, angulated channel. It's more it's more narrow than this very straightforward collagenous channel that in the perforating disorders. Where do we see the by the way, where do we see EPS? What's the mnemonic?
Mad pores.
Mad pores. What does that stand for?
Oh boy. M is Marfan's.
Mm-hmm.
I'm gonna need some help on this one. I think D
Okay.
is Down
Yeah,
syndrome.
yep, that's right. D is Downs. Okay, get as many as you can.
E is the drug penicillamine.
Yep,
I think O is OI.
yep.
Not sure what R is, and then there's Danlos,
Where's downloads? And then,
scleroderma.
okay, good. The ones you missed were A, acrogyria, and then you missed Rothman-Thompson. So mad pores, MADPORES, M, Marfan syndrome, acrogyria, D for Down syndrome, penicillamine, you got that one. Osteogenesis imperfecta, OI, yep. Rothman-Thompson, Ehlers-Danlos, and scleroderma. What's going on here?
I think I'm seeing a lot of calcification.
There is a lot of calcification. What's
And
the
there's
shape
like
of the
a
shape?
nodule.
It's a nodule. And is it subepidermal, intraepidermal?
Subepidermal mostly.
Subepidermal. So what do we call a subepidermal calcified nodule?
A subepidermal calcified nodule.
Very good. Next. Okay. What do we see here?
Some the papillary dermis looks a little bit pale. This whole thing is really sclerotic.
Yes, very sclerotic. Okay, perfect. You picked up on the two. These are the key points you want to pick up on low power for this. You see the sclerosis, but you also see the papillary dermal edema. Okay. By the way, what else is missing here? What do we not see? Adnexa, yes, good. We don't really have a whole lot of adnexa here. That's another feature of this entity. Sclerosis, papillary dermal edema, loss of adnexa. What kind of cells are here?
Fibroblasts.
Fibroblasts. What's up with the fibroblasts?
Some of them look stellate, perhaps.
Yes, look at this. Exactly. Perhaps they're stellate. Look here, look.
Well, I was looking for them to look stellate, so I
Here,
was
look,
like
look.
hunting for
What
them.
shape is this fibroblast?
Stellate.
It's stellate. It's a triangle. It's like screaming, I'm a stellate to you. Okay. What kind of fibroblast is that then? Probably with all this
radiation, whatever fibroblast.
Radiation fibroblast, exactly. So what has sclerosis, papillary dermal edema, loss of adnexa, and stellate fibroblasts? Your diagnosis is what?
Radiation dermatitis.
Radiation dermatitis.
Or chronic radiation.
Yes, chronic, exactly. Chronic radiation dermatitis. There you go. What's going on here?
Is that mucin in the deep dermis?
There's mucin in the deep dermis. In this case, you don't have to infer it based on the hydrostatic pressure. In this case, it actually stains.
I'm gonna go with scleroderma.
Scleroderma, good, yeah. So unlike in scleromyxedema, where there's mucin and increased cellularity in the top third, scleroderma is not an increased cellularity, but mucin in the bottom third. Scleroderma. Where do we see scleroderma? Two conditions, two cases, clinical presentations.
Diabetes.
That's it. Diabetes, okay. And then what else?
Post-strep, and then there's also a gemmopathy one.
Yes, good. Post-streptococcal, two big ones to know, diabetes and post-streptococcal. And this we went over, but because we went over because of a question, but this is top third, middle third, or bottom third?
Top third.
Top third, increased cellularity or decreased cellularity?
Increased.
Mucin or no mucin?
Mucin.
What's your diagnosis?
Scleromyxedema.
And the gemmopathy is?
IgG lambda.
Lambda. Yes, very good. The tissue is folded. Everyone sees the tissue is folded. Are we going to give up?
No.
Of course not. Of course we're not going to give up. We got this, guys. Where are we?
Going with polar skin.
Volar, excellent. Why Volar?
because of the stratum lucidum.
Stratum lucidum. And you don't have any? What
Hair
type?
follicles.
No hair follicles, stratum lucidum, hyperkeratosis, all volar. Okay, cool. What happened here?
See a large lumen.
Is it a lumen?
Is it just folded onto itself?
Well, I mean, there's something. Well, let's see if there's something inside it. There is some material inside this, but most of it is light, and it's not just folded onto. I mean, look, there's some processing folding, but there really is something that was here. You don't just get this like massive vacuolated space in someone's like finger or something for nothing. There is some the key here. So two things. First of all, if you see this, there's some inference work that you can do to get the diagnosis. But here you actually have a gift. You see the residual of what was shelled out, which is what?
Is this going to be like a digital mucus cyst?
It is going to be a digital mucus cyst, and you're seeing the residual
Mucus.
mucus. What happened to the rest of the mucus? The mucin.
Either we squeezed it out or like it escaped.
Yeah, processing is
Thing.
happening. Processing, shell out and processing all the time, or someone popped it during the procedure and the mucus squeezed out. Yeah, that's the thing that you commonly see when you see digital mucuses. You commonly see something like this, and you have to be able to say, "Oh, I'm on volar site. I see this cavity. Maybe I'll see some residual." But yes, the inference work is there for a digital mucus cyst. Don't expect to see on path like this beautiful mucin-filled component. Usually when the procedure happens, that all squeezes out, and then you have to go through the processing, which shells it out even more. And this is what you're left with. But that's okay, because we don't give up. We do the inference work. And we tell the clinician that they got the right answer. That makes us look smart. Clinicians always love it when we tell them our diagnosis matches theirs. Okay, here's the give me.
This is the epidermal. Oh, no, never mind.
Come on, give me 3 points. 3 points. Build your time.
Anchronosis.
Oh, chronosis. Good. Everyone sees the banana bodies here. What's going on here?
Lots of like little cysts.
Lots of cysts. Yes. What else?
Solar elastosis.
Yeah, these big cysts and solar elastosis, and there's keratin material in these hair follicles. It's like these comedominal-like changes with cysts, with solar elastosis. What's going on?
Fabry-Richet.
Fabry-Richet. Yes. And what do you think this patient does that we need to that we can hope they stop? In terms
Spends time in the sun.
Smoking.
Yeah.
Oh, smoking. I was
Both,
forget about that.
both. Yeah, no, both. You're both right. You're both right. They spend too much time out in the sun and too much time smoking out in the sun. Or too much time smoking indoors and out in the sun. But yes, that's Fabry-Richet. Okay. What are we seeing here? Hit the category before you don't think of just diagnosis. Don't jump the gun. Just like be broad.
Maybe like a little interstitial infiltrate.
Okay. And then what's all this?
All like collagen.
Yeah. There's sclerosis here. This is a sclerosing disorder. Okay. But yes, I agree. There is some increase there. And by the way, there's some mucin here. You can see the blue tinge. There is some mucin, there's some sclerosis. There's another finding I want to show you. There is some condensation of the collagen into a ball-like little ball materials, little globes here, here, here. They're condensing. And in some of them, in some of these bodies, you can see, what does this look like? Go perforating through the collagen ball. What does it look like?
Elastic fiber?
Yes, an elastic fiber perforating through a collagen ball. If you see this, you're very lucky. And you could look very smart getting this diagnosis. But without that, we would just say, oh, we know, okay, look, there's some sclerosing disorder. There's some areas of fibrosis and mucin. This could be a number of things. This is a money shot. This will tell you that there is, you basically just clinch the diagnosis when you see this. In fact, I'll give you a stronger example. In later stages, it looks like this. These are called the elastocollagenous balls of, and they used to think it's pathognomonic for the entity I'm describing, but really it's pathognomonic for the cause of the entity I'm describing. Does anyone know what this is, by the way? Patient had kidney problems, and the patient had so I'll just skip to the chase. So this is NSF, so nephrogenic systemic fibrosis. These elastocollagenous balls they used to be thought to be pathognomonic for NSF, but they're actually pathognomonic for any lesion caused by the etiology of NSF, which, by the way, what causes NSF?
Gadolinium contrast.
Gadolinium contrast, exactly. So they used to think that these elastocollagenous balls that you're seeing over here are pathognomonic for NSF. They found any gadolinium associated lesion, be it NSF or anything, can actually have these elastocollagenous balls. So it's not exactly true. It's not pathognomonic for NSF. It's pathognomonic for gadolinium. But yes, but once you see this and put it together, when you see, okay, I see the sclerosis, I see the these areas of fibrosis, this mucin, and then you can clinch it with elastocollagenous balls. You can say, okay, well, this is nephrogenic systemic fibrosis.
And that one has the positive CD34 as opposed to Morphea.
Opposed to Morphea, which, by the way, what is this?
Morphea.
Yeah. Is it, what stage of the Morphea is it? I'll give you a hint. Look at all of this.
Inflammatory.
Inflammatory Morphea. Yes. So you have all the signs. I mean, look, you have your square biopsy, but you also have these pronounced areas of inflammation. Yeah, inflammatory Morphea. And you can see lymphocytes, you can see plasma cells. Okay, and you see the fat here again. You see these adnexal structures without their fat. There's no periacrine fat here. Okay, and this? Look at this area right below the epidermis. Is it light compared to this? Maybe not as obvious.
I'll say yeah.
Yeah, light compared to this, which would indicate what? This is an area of
Pallor.
pallor or papillary. Well, not pallor. Pallor we would just
Yeah,
describe.
edema.
Papillary dermal edema. What are we missing? Do you see any hair follicles? Are they anywhere?
Is the fat really superficial, or is it just like a bizarre cut?
That's a good, yeah. So that's a good question. I don't think the fat is just herniating here. I think that there is artifact here, and the reason I'm saying that is because you have like areas like this as well.
Yeah, it's like all weird.
Yeah, but it's okay. Are we going to give up?
No.
Of course not. Of course not. We know we can work through all of these artifacts and all of these terrible biopsies. It's fine. We got this. Look, papillary dermal edema. Regardless of the quality of the biopsy, we know that there's no hair follicles, right? And we don't see a whole lot of what? Agnexa in general, right? And what's going
Right.
What cells do you see?
Still 8 fibroblasts again.
L8 fibroblasts. What is this all telling you again?
Radiation.
Of course.
Maybe that's why it's messed up.
That's, well, one of the reasons. Yeah. And also, I mean, look, the skin is janky. I mean, that's probably also why the biopsy quality is not that great. But okay.
Ooh, this is pretty.
Here's the give me, guys. Give me 3 seconds and build your time on for the next question. This is a what?
Sclerotic fibroma.
Plywood fibroma is a thought, but what's wrong with plywood fibroma here? Or sclerotic fibroma?
It's like too thick. The bundles are too thick.
Too thick. And what color are they?
Bubblegum pink.
Bubblegum pink. So what is it?
The keloid. Why is it so like blue in the background?
Oh, I know.
Is it just weirdly stained or?
So there's different ratios of hematoxylin and eosin staining. Work around it. But yes, when you see bubblegum pink collagen like this, it's always a keloid until proven otherwise. Nothing else looks like this. Even hypertrophic scars don't look like this. And in terms of plywood fibromas, the collagen is not that thick. It's more, so it's more thin and it's more of like this homogeneous type of like whirly swirly, like storyform sky pattern, which you see a little bit of that here, but it's too bubblegummy and it's too thick. So you can get some simple things like this. Keloid. Okay. It's subtle over here, but let's stain it. Okay. We'll go for the stain. By the way, what kind of stain do you think this is?
PVG.
Yeah. Which stains what?
Elastic fibers.
Elastic fibers. Okay, so what's going on?
They're missing in
Where are they?
like the more superficial dermis.
The more superficial. So here?
Oh, in the mid dermis.
In the mid dermis. Good. So it's there. It's in the superficial dermis.
Oh, yeah.
This area is gone. Right? We have it here. We have it here. We do not have it here. So what happened?
So this is mid-dermal elastolysis.
This is mid-dermal elastolysis. Exactly.
I missed the stain, Avi. What was that again?
VVG. Verafangisen.
Thank you.
What's this one? And now look at this. What happened here?
Microtome.
Look at, what are we staining? What's the stain for? I mean, so yes, there's an art. You're pointing out the artifact here. That's fine. But what stain is this?
Another VVG.
Another VVG. Yes. And where and what's happening? So where do we have? We have it here, right? Elastin fibers. They're great.
It's missing throughout the dermis as opposed to just the mid dermis on the
Yes.
R.
This whole area is gone.
Is this like an anatoderma? Natoderma?
Yes, a netoderma. Yes, so that's how you differentiate a netoderma from middermal elastolysis. So middermal elastolysis, it's all about where the elastin fibers are missing. As the name implies, with middermal elastolysis, this name makes sense. Middermal elastolysis is in the middermis, and the elastolysis happened in the middermis, so it's gone there. Contrast that with a netoderma, it's not horizontal, it's vertical. Top, bottom. right? So it's instead of the mid-dermis being elastalized, it's throughout. That's going to be an etoderma. There are some things in dermatology where the names don't make sense. There are some things that make sense. I have enough time to do a little bit of a rant of things that don't make sense. Look, we've done some mess ups in dermpath. Like dermpath community has gotten certain things wrong. In fact, we'll have enough time to talk about dysplastic nevus. That's another one because this is important. You guys may not be as important for the boards, but you guys are going to go out and practice, and a whole lot of people don't know. There's so much misinformation about it. So just like mycosis fungoides is not has nothing to do with mycoses. Dysplastic nevi per se has nothing to do with dysplasia. But how many of you guys are seeing? There's so much. It's so hard to navigate dysplastic nevi as a resident. But when you get what are your guys' impression of dysplastic nevi? When you get like a path report for dysplastic nevi, it comes back and it says, "Oh, a dysplastic nevus, moderate or severe atypia, recommend re-excision." Is the impression that you guys have, is the belief you guys have that what's going on there is like there was the criteria for dysplastic nevus that the pathologist found and that was met, and there were features for the dysplastic nevus that were indicated it's severe enough such that the dysplastic nevus is a precursor to melanoma and should be excised. And it's okay if you have that impression, but how many do you guys have that general impression of that's the meaning?
I think it has been emphasized to us that that is not the case and that they are not precursors to melanoma. And while that is a controversial point, the correct answer is that they are not precursors to melanoma.
Good. Yes. So if anyone, good, I'm glad that has been emphasized in it. And I'm guessing that's been emphasized by Dr. Neat.
Yes.
Okay, good. Good. I'm glad they're excellent. Because it's not true. A lot of people have this impression that when they get their excision of a dysplastic nevus or it's a biopsy of dysplastic nevus back, and it's what's happening is the reason they're writing severe atypia, or the reason that they're signing it out as moderate severe atypia and recommending re-excision is because it's a precursor to melanoma. If anyone has that belief, what I want you to do is I want you to extract that belief from your mind. I want you to walk over to your toilet. And I want you to flush that belief down the toilet because that's where it belongs. Garbage. Completely not true. So what's actually happening? What's actually happening with dysplastic nevi, at least here at Mount Sinai, first of all, what's happening is a whole lot of different things. You have to know your dermatopathologist and what they mean by their semantics. But what really is happening is dysplastic nevi are really just like any other nevus. But what's happening here is that just like any other nevus, sometimes you can have features of melanoma, which, by the way, are not part of the WHO criteria or even previous criteria for dysplastic nevus. So a pathologist can look at a dysplastic nevus that meets WHO criteria for dysplastic nevus, but has some features that are also concerning of melanoma, but not enough to call it a melanoma. And then what happens there is the dermatopathologist is couching that concern. They are taking that concern and they're feeding it into the grade. And that's why they're signing it out as moderate or severe. Not because they're following the WHO, at least for those dermatopathologists, not because they're following the WHO 2018 criteria for severe. It's because they're concerned. They're looking at it, they say, okay, this is dysplastic nevus, but I'm seeing some features of melanoma. I want the clinician to remove it. And what I'm going to do is I'm couching that concern into the grade and I say it's severe. And sometimes they'll also give a recommendation for excision depending on what the clinician preference is. And sometimes they'll say, they'll just write out what the features are, even better. But that's what's happening. But the point is that has nothing to do with dysplastic nevus per se. If you have features of a melanoma in any nevus, you have to convey that to your clinician. All that's happening with dysplastic nevus here is just you have another way of conveying it to a clinician, which is a really silly way of doing it, but it happens, which is just you're conveying it with the grade. You're concerned about it with the grade, and so you're couching that into the grade instead of just saying with a junctional nevus or a compound nevus or a blue nevus or a dermal nevus. You would just write out like, hey, there's features concerning of melanoma. Here's the atypia. Here's this. Here's why. Here's recommend re-excision. It's a much more straightforward way of conveying that concern to the clinician. But in reality, there's nothing magical about dysplastic nevus, and there's nothing dysplastic per se about dysplastic nevus. That's a myth. It's not true. All that's happening is that when you see features concerning a melanoma in dysplastic nevus, like any nevus, we write, hey, we need a way of conveying that to the clinician. And that's fine. It's okay. It's totally fine to convey to your clinician, hey, this is a dysplastic nevus, but it could be a melanoma. Here are some features, not enough for me to call it, but out of concern, excise it. That's okay. But that's not magical. That's not unique. That's true of anything. It's true of a dermal nevus. It's true of a junctional nevus. It's true. All you're doing is different semantics. And it's very important because we do that. I know that this is how the dermatopathologists here do that, but it's not necessarily the case that if you go to another institution that they're going to use the same semantics and couch this concern in the same way. So you have to know your dermatopathologist and you have to know what semantics they use. What do they mean? When they say you have a dysplastic nevus with severe atypia, what are you talking about? What does that mean? Does it mean that it's severe atypia based on WHO criteria? If so, who cares? Because there's absolutely nothing about severe criteria in WHO 2018 that indicates there's a transformation risk for melanoma. There's also nothing that indicates that it's going to be a melanoma. Or are you saying you're calling it severe because you actually saw features that were not part of the WHO criteria for dysplastic nevus, but were the conventional features of melanoma? Did you see pagetoid cells and pagetoid pattern? Did you see single cell melanocyte predominance over less of melanocytes? Is that the sort of thing you saw? If so, tell me that, or know your dermatopathologist and what their general practice is. That's the key. Okay. Rant over. Okay. But look, here's the thing. Sorry, rant not over. Just a few more. Because we've used this name, dysplastic nevus, what has happened to patients? What do you guys think? Like, because I can tell you this, I can break down the semantics and what's going on behind the hood. But what do you think happens in practice to patients because of this?
They get unnecessarily out.
Yeah, not just unnecessarily biopsied. They get not just unnecessary biopsy, excisions. You get these young patients, not with CDKN2A mutations, not with a history of melanoma or anything like that. They just get hacked. They get chopped up for nothing. Not just unnecessary biopsies, unnecessary excisions. And it's just because we've had this type of taboo word for this nevus, when really, if we just had some any other type of word, which people are doing. You go ahead.
So Avi, so I don't want to take up time for your guys' didactics, but whether you call it dysplastic nevus so you're saying there's no such thing as dysplastic nevus. There's a nevus. It either has features of melanoma or not, and if it doesn't, you're not worried about it, and if it does, you should re-excise it.
Yes, that's right.
But when someone says dysplastic nevus on a biopsy, now it renders this kind of area of confusion because you say you don't know what they're talking about. But I would say that things do evolve, and maybe you called it a dysplastic nevus, but what you really meant was an evolving melanoma very early, and you should cut it out. I just don't want people to walk away from this not cutting out pigmented lesions because it, there are definitely pigmented lesions that warrant to be cut out, and if you're,
So of course you can. So yes, and you can have pigmented lesions that can evolve into melanoma. But I will tell you that there's no evidence that a dysplastic nevus per se, without any features of melanoma, has any more of a risk of evolving into a melanoma than a dermal nevus or a junctional nevus or a compound nevus.
Okay, I see what you're saying.
Yeah.
Okay.
So that's the point. The point is not that, yes, there are criteria, there are certainly cases where you have to okay, if you have the ugly duckling sign, if you have a baseline risk probability, if you have CDKN2A mutations, if you have a family history, yes, you're gonna make a clinical decision to do biopsies, to do excisions. But just so you know, a dysplastic nevus as defined by WHO criteria per se has no more of a risk of evolving into a melanoma. There's no evidence for that.
Are we aren't we evolving into genetic characterization of these things anyway? So that you kind of sidestep this whole like visual.
So yes and no. So we are, and I will tell you. So I'm gonna just show you this right now. We are evolving into genetic testing. And I wrote a paper on the problem with that. Okay. So this is my paper on the issue. So yes, we are evolving in genetic testing, and there are all sorts of tests. This is my critique of the MyPath test, for example. And in the issue with that is a lot of these genetic tests are based on circular reasoning. The problem is what they do is instead of looking at the outcomes, now not all of them do that. So like the decision DX, for example, that's one that actually has good outcome data. But if you are going to, and you can look at the genetics of dysplastic nevus versus or in subtype the dysplastic nevi versus the junctional melanocytic nevus or compound melanocytic nevi, and you can have some sort of prediction of transformation. However, here's how you have to do that. The way you need to do that is by outcomes. If you just look at the genes and then you feed that back into what a dermatopathologist is saying. So say, oh, okay, well, how do you know this ended up being a melanoma versus a benign nevi? It's based on what the dermatopathologist said. There are tests that do that, but all you're doing is proxying the same issue in the first place. What you're doing is you're constructing a genetic test to basically recapitulate what an expert panel of dermatopathologists would say instead of looking at the outcomes. So yes, I grant that you can have a theoretic test that will be able one day, we don't have this now. So we haven't done this yet, but there will be there theoretically can be a test that will predict transformation risk of dysplastic nevi, but it would also predict transformation risk of junctional melanocytic nevi. It can predict transformation risk of a compound melanocytic nevi. And the issue is there any reason to believe that these tests will indicate that there is an increased risk of transformation of dysplastic nevi per se, not with features of melanoma, but per se, than any other one? And the answer is right now, no. Right now, there's no evidence that indicates that there's any reason to believe, based on outcomes, that any of these tests have indicated that this dysplastic nevi per se will have an increased risk of transformation compared to any other nevus. And by per se, I mean based on the WHO criteria 2018. It's just not there. And so this is not to say don't excise pigmented lesions. It's not to say don't biopsy pigmented lesions. It's just to say,
or not to say biopsy, but like if you have, but the reason they're calling out the severe dysplasia is because there's something in their gut that says it's looking funny.
Yes, that's yes, exactly. But that's the key point, Dr. Levitt. The key point is that it's what they're saying to you is that, hey, what they're not saying to you is that there's a difference between when you say something is severe, because there is a WHO formal criteria for what severe means. And what you just described, Dr. Levitt, is not that. What you just described, when your dermatopathologist looks at the slide and says, oh, it's severe because something looks off, something looks concerning to me. That's not severe by WHO criteria of how you're supposed to classify dysplastic nevus as a criteria. What they're doing there is they're importing something else. They're importing their concern. They're concerned about melanoma. They say this is something that looks like it could be
right.
melanoma.
So the thing is, I hope people aren't walking away saying, oh, well, if something says severe dysplasia, dysplastic nevus, severe dysplasia, that the dysplastic nevus is trumping the thing, and so don't cut it out.
No.
Or is it the severe dysplasia that's trumping the thing and saying cut it out?
Yes. Yeah, excellent. So when you see severe dysplasia, the key is to know your dermatopathologist, and you can even call them and say, what does that mean? It's not that the dysplastic nevus is trumping severe dysplasia and leave it in. What is the reason that they're dermatopathologist? Because I can tell you, I know some dermatopathologists that practice this way, that they actually just straightforwardly practice by the WHO criteria, and they will call something that Dr. Neat would call mild dysplastic nevus, they will regularly call it severe dysplasia. because it meets WHO criteria for severe dysplasia, and they're not concerned about melanoma at all.
Will they say on the report conservative re-excision advised or no?
Sometimes, so it depends. And again, there's whole data. There's data on this, and it's all over. That's the sad part. It's all over the place. This is why you have to know your dermatopathologist.
All right. Well, I suggest we move on.
Yeah. Okay. Well, actually, we're out of time. It's 11, but I'm actually glad we had this. We talked about this. This is because this is a whole messy field. So just if I can let you guys take away with anything, it's know what it means. When you get a report of dysplastic nevus with severe atypia, fortunately, usually what the dermatopathologist is telling you, I will tell you right now, is that you should cut it out. And you should cut it out because they're concerned. They're concerned that maybe it's features of melanoma there. However, I will tell you that there are institutions where that's not the case, and they will still call it severe, even though some dermatopathologists here will say, hey, that I would call this mild because I'm not concerned about melanoma, even though it meets WHO criteria. So if there's one thing I can tell you, it's not just to ignore, not to just not biopsy, not excise, but to know the semantics of your dermatopathologist. Know what your dermatopathologist is trying to tell you when they give you this, just because of how non-univocal these things are. And then make your clinical decision. Fair enough?
Sure.
All right. You guys did great. Good job, guys.
Thank you.
For sure.
Thanks so much.
For sure. Take care, everyone.
Thank you.